So now I'm just going to talk to, and very briefly, on a number of disorders and just say a few words about my experience with those disorders, and maybe my observations will prove useful for you. So the first is just addiction. And the way we look at addiction is that it's really largely self-medication for anxiety and depression. That it's less about craving than it is about self-medication. And even when someone, let's say, I remember one methamphetamine junkie in particular, that we can think it's all craving, but when I speak to him and to others like it, that when they quote that they really need to do it, and when they do it is when they have an episode of anxiety. So it's useful to think of it that way. And I think the main reason it's so damn hard to stay abstinent is because you still have the underlying anxiety, depression. So I've also found that direct neurofeedback can be very effective treating the detox aspect at the front end, not just a little bit down the road. And the ones I've treated needed far less medication to detox than they did otherwise. And one of my friends, highly functioning working alcoholic, who periodically just stops drinking, he invariably gets DTs, ends up in the hospital seizing, and that's been his pattern for the last 20 years. So we did it together this time, and I treated him with direct neurofeedback for the first few days every day, then every other day, then every fourth day. And in 2 weeks, he was essentially detoxed, stayed out of the system the whole time, never had a seizure, and did quite well afterwards. So this could have a much greater role in addiction. And I know there are a number of studies about addiction and the effect of standard neurofeedback that have shown it effective also. Just one final point about, two, about addicts. One is that they really think they're screw-ups because they've tried to get abstinent so many times and they've failed so many times that initially when I treat them, they're sure that this is just one more time that they're going to fail. This may be helpful with other people, but not with them. And one thing I tell them is, you don't have to believe in this. We don't have to bond. You don't have to like me. It just works. And further than that, there's nothing you can do to stop it from working. And it's true. There's nothing they can do to stop it from working. And that's what happens pretty much invariably. One final point is that when someone is self-medicating already with marijuana or drinking, I don't get them to try and stop. That everyone wants to be off these things anyway. And as you take care of the anxiety, depression, that they go off on their own without you even asking them to. And I found that that's worked quite well. Okay, next is autism. That autism, as everybody knows, is a very complex disorder and multifactorial basis for its cause, genetic, environmental, etc. And they can have such a wide range of symptoms. So we certainly don't cure autism, but we've treated quite a few, and we find that we're often very helpful. Certain aspects of the autistic, someone on the spectrum, is that they tend to be hypersensitive to the environment, often to sound, sometimes to light. Many have ADD also as comorbid disorder, that they are very reactive and have meltdowns, and then it takes them a long time once they've had the meltdown to bounce back up. They don't have much resilience that way. And a lot of them just have anxiety, and there's more. And I find that when we treat those on the spectrum who have problems like these, that they do quite well. And life becomes a lot easier, not just for them, but for their parents. So it is certainly worthwhile. It can be very gratifying treating someone on the spectrum. We sometimes then see other aspects open up that we didn't particularly predict. Like sometimes there's better communication. I had one client who was Pakistani, and he was about 14 years old, and his parents spoke Pakistani to him, but he never responded in Pakistani. So they didn't even know whether or not he spoke it. And after about 6 sessions, he started speaking to them in Pakistani. And you can see breakthroughs like this. Here they come, you don't expect them. I don't say that we can get it all the time, but they happen. Okay, depression is depression's a little tricky. What I found is that when you're depressed, your feelings are down low, and you're not really going to feel better till you're up here. Yet there's a whole range in between those two where there's room for improvement, but you still don't feel better. And so the focus then has to be on behaviorally, what are they doing? Are they, let's say, cleaning out the garage when they weren't before? Are they calling someone where they weren't before? And it often takes someone outside of the person who's depressed to point these out, because they really don't feel better initially. So they need this kind of encouragement that it is working, even though they don't feel different initially. So depression. I find also that there are milder forms of depression that aren't often recognized as incipient depression. I mean, one would be, my sense is procrastination. They just don't have the energy nor the psychic energy and wherewithal to get stuff done. And so there's a lot of low-level depression that we think is either just have no energy, character problem, etc. A lot of it, at least a fair amount of it, is low-level depression. Okay, unipolar, bipolar. It's bipolar is in general harder to treat than unipolar, but I have had some very good successes with it. I also find bipolar probably the most unrecognized psychiatric disorder there is, that many psychiatrists often don't pick up on it. And even if you're not a psychiatrist and you're not prescribing medicine, I think if you are sensitive to when someone is bipolar, at least acknowledging that and suggesting that they see their psychiatrist or family doctor, whoever, because it's very different medication whether or not you're bipolar or just unipolar. Okay. Anxiety. Well, what's interesting is that anxiety attacks, the more dramatic aspect of it, they generally resolve quite quickly. That the acute phase becomes more stable and they become less reactive. And it's very gratifying to see that that's the aspect that often the client fears the most, but is not a problem to take care of. Then it's the generalized background anxiety that is much more work. Sometimes you see also anxiety when your client is overstimulated. Sometimes it presents as muscle tension, or they just start to physically feel it somewhere in their body, and they just don't feel good. So to be aware of that. Oftentimes I ask patients when they feel something, and I'm not sure whether it's a positive feeling or not. I ask them, is it positive, negative, or neutral? And they're usually able to give a response, and I've found out if it's positive, it's fine. If it's negative, even if it didn't necessarily seem that way to me, I'd proceed on that assumption. And it has been very helpful. OCD, just briefly, helpful with OCD, because anxiety drives OCD a lot. So the greater the role of anxiety in someone's OCD, the more direct neurofeedback helps. and the more it's not related to anxiety, were less helpful. In terms of insomnia, I find insomnia is difficult. When it's insomnia associated with anxiety or depression, it often improves. But what I call isolated insomnia, insomnia not associated with another disorder, I don't have great success with, and often encourage a client, if I can't help them, to seek help elsewhere with it. Finally, not finally, but there's some areas that I've found respond really well that I never expected to. One is fibromyalgia. I've had significant success on most of those I've treated. And others along that line with chronic fatigue. It's been trickier with Lyme's. I don't feel like I have had that much effect in Lyme's. And then there are other areas that are just ripe for investigation that I've treated some, my colleagues have treated some. And one is Parkinson's. I've had dramatic changes in Parkinson's. And another is strokes. You know, I've treated several strokes way beyond the 6-month, 12-month period when most rehabilitation is most likely. And they did very well. And remarkably enough, starting with the first session, just like with all the other disorders, first session. The same is true for traumatic brain injury. I mean, when I first got involved with direct neurofeedback, why I ignored it initially was because of its claims about treating traumatic brain injury. And damn, if it doesn't, it does. And it starts getting better the very first session. We did an informal study with former NFL players, 9, at UCSD, University of California in San Diego. They did a small clinical case series of 6 people, all with head injuries. And now there's a large study, double-blind study at UCSD that for PTSD and TBI, traumatic brain injury. And this will be an historic paper, and the world will know about it.